We appreciate everyone taking the time to join us today for our Learning Cafe. This is our June Learning Cafe. We will go ahead and get started today. Again, so we're fortunate, although I guess we've got Drew all the time, but we don't always get him wrangled into presenting. And so I'm very glad that Dr. Burkley, one of the psychologists here at COE, was willing to do this presentation for us today. It's one that I think is going to be really good and really valuable, and is one that people have asked for. And so, Dr. Burkley has been with us for more than 5 years at this point, and divided by some time. I guess we piece it all together, probably looking at 7 or 8. But Dr. Burkley is a licensed clinical psychologist at the COE. He graduated from Chestnut Hill College in Pennsylvania with a doctorate degree in clinical psychology. He's also a nationally certified PCIT regional trainer for Tennessee, which is a super huge deal. And he is trained in several therapies that help children and adolescents overcome trauma. Through the Center of Excellence, he routinely provides guidance and recommendations on improving the relationships between children and their caregivers, and his clinical focus is on young children with disruptive behaviors, trauma, and those involved in a child welfare system. Today, he's going to talk to us about using collaborative problem solving to help families work together. And so I hope you all will join me in welcoming him to speak to us today. Thank you so much, Dr. Burkley.
Thank you. I'm very glad to be here. And likewise, my office is a little bit hot, so I'll be drinking a little more water than usual as we try to overcome the lack of air conditioning. So thank you all again for coming on. I'm very glad to talk about this with you. I received my training in graduate school with someone who had worked with Drs. Avalon and Green in coming up with collaborative problem solving. And so I was very honored to be able to have that experience. And so to give you a little bit of history real quick on the collaborative problem solving model, the two creators of it have split off, and there's lawsuits about it and a whole bunch of things. And so you'll find information on collaborative problem solving from Dr. J. Stewart Avalon at the University of Massachusetts, and also Dr. Green. They're both equally effective, pretty much. They go at the same things. They just have different copyrighted terms and things like that. And so you are free to use whichever method you all find as you go out and find literature on it. I'll be presenting the terms that Dr. Green mostly uses, since that was where my training occurred. So anyway, real quick, I want to see if my slides will advance. There they go. Thanks again to Dr. Green, who came up with it, and Dr. Avalon. There's a nice book out here called Explosive Kids, which is meant more for providers and therapists than for the parent. Dr. Green has a book just called The Explosive Child, which is a great, very well written, very readable parent guide to the treatment. And so I often recommend that book to my parents. It's a good bibliotherapy, and it's something they can just use some guidance on. And it's very, very amenable to parents who are willing to do a little extra there. Explosivechild.com is their website. These slides, again, I have to give credit where credit is due. My colleagues at Chestnut Hill College helped me create these, as did my guiding professor, Dr. Browning. All right, so the idea for a new paradigm. This idea that what we have now is when we think of kiddos who are defined and disruptive, we often think that they're just being punks. One of my favorite things, PCIT, often takes it from that perspective when we're talking about younger kiddos, is they're disobeying just because there's a bad relationship, or they don't feel like obeying, or they're defiant. But there's other reasons that sometimes we neglect about why kids do things. And so we're going to take a look about how we label kids and adolescents first. So we have these different labels of children, like they're defiant or aggressive or non-compliant or challenging. There's dangerous diagnosis, not dangerous, but there's a number of diagnoses they're given: oppositional defiant disorder, conduct disorder, intermittent explosive disorder, ADHD, and so forth. And we label and we provide these kids these pretty big diagnoses. And I think one of a colleague at a training once said that the ADHD is pretty much a door prize diagnosis for when kids enter state custody a lot, is they pretty much get one swept into that and ODD. And indeed, there are common co-occurring disorders. The difficulty with that, when we look about these diagnoses, especially with ODD and conduct disorder. We tend to look at kids who start to label them and define them as just being punks, being non-defiant, being, and that's the only reason they're doing it, is they just don't like society and they don't want to listen. That's the whole reason. CPS, as we'll get into, takes a bit of a different framework on why kids disobey. A sneak peek is it has to do with more skills deficits, is the way they frame it, versus just not wanting to obey. And so we're going to use the term explosive here because it's common among all these descriptions of diagnoses. And often you'll hear parents, right, say my kid goes from 0 to 60 very quickly. I just say, hey, you can't have that, and boom, tantrum. Or I said we're going to the park and he loves the park, and boom, a tantrum. They'll say it often comes out of nowhere. And so these parents are really often describing explosive kids, right? They just happen, they don't see a precursor to it. And indeed in therapy, when they talk to you, it's hard for you to see there's an antecedent because they just gave a very innocuous thing. We're going to the park, or we're going to see grandma, and something that had maybe caused a tantrum before all of a sudden does. Or maybe it is something that's repetitive and it's nothing like large or disciplinary. And so we use the term explosive there just because it's something that's common. So when we talk about CPS, this collaborative problem solving, what makes it different? It assumes that our explosive kids are just really not understood, that they're not addressed very well by available therapies. There's reasons for a tantrum. There's understanding, and by understanding those problems, we can prevent the future tantrums. CPS kind of takes this idea that a tantrum that a kid has is unique. Each tantrum they're having is unique, has unique reasons and motivation behind it. It also takes the idea that the kid is throwing a tantrum because that's the best way they know how right now to communicate their needs. And I'll often say, never underestimate the amount of energy it takes a kid to throw a tantrum. Part of what we're all doing is trying to find an easier way for a kid to find their needs to get met. And that's a common thing among a lot of different therapies, especially when we look in schools for functional behavior analyses that kids often have. They're looking for easier ways for kids to get the needs met. That's one of our kind of like goals for almost all therapy, is how do we get this easier for the kid to communicate? So it looks at it as more unique. Now, those of you who may be familiar with my work, and as Dr. Corwin talked about, I'm a PCIT regional trainer. And PCIT takes a bit of a different approach. PCIT, I say to parents what the parents say is prophetic. If the parent says, give me the toy, the kid's going to give the parent the toy, whether or not they want to. They're going to give the kid the toy. I don't say they'll like it, I say they'll do it. I get kids to sit in the chair and pretty much listen to a parent when they say a command within about 10 seconds. CPS, again, takes a different approach to those, but they're not mutually exclusive. When we talk about small immediate needs, like getting in the car or putting your shoes on, CPS does not work very well in the moment for needs. They have this thing called Emergency Plan B, which we'll talk, but even that at the time, it takes a little bit of time. So what CPS is good for is repetitive issues. So if we notice every time we go to gymnastics, little Johnny throws a tantrum, or most of the time he goes to gymnastics, he's throwing a tantrum, or baseball, or he's not doing homework, or the kiddo's having problems with kids at school and does not want to go to school. CPS can be very good for things like that. And so again, taking this idea for gymnastics, when we tell a kid it's time to leave from gymnastics and the kid throws a tantrum, using PCIT, I can get that kid in that car, no problem, no easy peasy lemon squeezy. But what you're going to have though is a sour kid, a kid that does not want to be there. And if a kid's not enjoying what's going on, what's the point of it? And so what CPS does an excellent job of is trying to solve the problem of why is this kid having a tantrum about it, and how do we prevent it, and kind of address the issues they're having. A lot of times, and what PCIT does is it just focuses on reducing the tantrum, pulling back from the tantrum, and not getting that, because the kid knows there's a consequence what comes up. But it doesn't do good at necessarily preventing or addressing the want of the kid or the underlying issue. So CPS does work well with other therapies. Also, CPS, they say it'll go down to 2 and 3 year olds. It's a little more challenging than when you're doing it with, say, a teenager or an 8 or 9 year old. There's a little bit more barriers when we talk about linguistic issues with a 2 or 3 year old telling you the reasons why. and being able to communicate that, and then again helping you come up with solutions and sticking to them. So PCIT is for a much younger demographic. So as I talked about earlier, CPS looks at global domains that are causing issues with the kid wanting to do it, whether the kid's having a low frustration tolerance, having difficulty with adapting, not able to just being able to problem solve. We're trying to identify the specific factors that are contributing to the non-compliance. And it does this through certain pathways and triggers. And so we need to identify those pathways. There's different assessments, or I'm sorry, different areas that they're looking at. From executive skills, emotional regulation skills, language processing, cognitive flexibility, and social. Part of the program of collaborative problem solving, and that's both a therapist manual and the parent pathway, is just a questionnaire that's going to help parents tease out, where's my kid having the difficulty? What is going on that's likely contributing to these tantrums, to this defiance, to these other issues? And again, when we look at the diagnoses that are most common with what we're working with, executive functioning skills, emotional regulation skills, those all play into the diagnoses that we see, right? And I'm sure when you're thinking about kiddos that have ODD and especially ADHD, there's absolutely executive functioning skills going on. That's almost a definition of ADHD, right? It's an executive functioning disorder. And so helping parents tease that out and explain to them, helping to view the kiddo through this kind of a lens. And this lens works whether or not there's trauma there, right? As we're looking at them through a skills deficit lens versus a defiant and explosive lens. And now we start to have understanding. And that understanding is what plays into CPS an awful lot and is really essential when we start going through the phases of treatment there, or phases of problem solving. And so identifying those, and again, if there are language and speech delays and so forth, helping identify, not necessarily giving a kid a speech exam, the manual doesn't, but it does, if there's language and processing, you certainly want to get supplementary services for the kids, right? And address those issues. So there's identification of pathways. Now we're going to talk about the identification of triggers. We have talked about sensory hypersensitivities, transitions, the triggers academic tasks, interactions with peers, adults, families. CPS wants to get very, very specific about what the underlying problem is. When the kiddo says, I just don't want to go to gymnastics, that's great. Now we've got an idea, but that's not very specific, right? I don't want to go. I know you don't want to go. And then we do this idea of drilling down, because we really need to figure out, is this a transition that he doesn't like leaving what he's doing? Is it there's something about the room that he doesn't like? Is it the peers bullying him? I don't want to go has a lot of different triggers built into it. And so specifying those is a process. And it can be a frustrating process because it's not always going to come easy. We talk about that when we say about CBT, is kids aren't always going to be able to immediately put together their thoughts and feelings. It takes work. It's much easier to think about the feeling than it is sometimes to pull out the thought from it or the reasons. And so we have to drill down there. So really should have taken the animations out of this. There's two ways that we look at for identifying pathways and triggers. The most common one we're going to have is a clinical interview with a therapist or psychologist. Looking at, we're trying to look for ABCs, the antecedents, behaviors, and consequences, kind of getting more specific ideas of time and things like that. So the clinical interviews that therapists do can be very helpful about identifying pathways and triggers, in addition to formal assessments. And this might be a psychological you've had done on a kid where there's some behavioral measures in there, or again, the assessment that's included in the parent and therapist manuals there. It's kind of a semi-formal assessment, really. But those are going to be more helpful in identifying what's going on with the kids so we can address it, right? So our goals of our clinical review are always going to be to assess safety, right? That's our always number one goal. My professor said that repetitively, and I know you all say that. We got to make sure we're safe. The other thing that sometimes can get lost with clinical interviews, and I kind of blame this at times on sometimes time constraints that a therapist may have, or this idea that we have to get certain things in session and we have to check all of our boxes. But really, we're talking about parents who are just at their wits' end with their kiddos, who have explosive behaviors, is empathic support for them. Parents need to be believed. If they're therapists on the call that work with kiddos who have disruptive and explosive behaviors, I'm sure it wouldn't be it wouldn't be the first time a parent would say, or this isn't a surprise, a parent say, let me show you a video of his tantrum. See what he does. And they'll go out on lengths to almost tell on the kid and try and give you all this evidence. And that's kind of a sign that maybe people haven't believed them in the past. All right. And this need to be believed, this need to have empathic support, doesn't mean we're going to believe the parent when they say their kid's a demon. But we certainly will empathize with all the troubles the kiddos that they're going through. I often say, even for PCIT, right? I say it's for parents that love their kids and don't like them. And again, who would like the kid that's throwing a tantrum when you're trying to go out to a nice restaurant? Who's punching holes in your wall or breaking your nice things? You know, it's the epitome of, this is why we can't have nice things. I'll never forget very clearly when I was a practicum student in my master's program, there was a parent, and I didn't have all the skills I nearly have now. I was fresh out of grad school. The parent was just trying to take their kid out to a restaurant because it was their birthday. And the kid was climbing, just explosive behaviors, and she was in tears as she was telling me this because she was at her wit's end. She didn't know what to do. We need to believe our parents. We need empathic for them. Even though we're checking our boxes, that part, when we talk about engagement strategies, that empathy is really crucial here. And the other part, especially for CPS, and we really should be doing anyway, is just assessing for pathways and triggers. Knowing what's going on, getting antecedents, behaviors, consequences, understanding and kind of getting an idea of a regulation and skills deficits. That's really helpful when we talk about treatment planning. So, getting everything together. All right, so what do we do once we have all this information? We've got some great stuff. Sometimes if it's appropriate, meeting with an older kiddo alone to get their idea of things, asking them some questions about what their tantrums, what's going on with them. Of course, and this is a phrase we'll repeat as we go through here. We don't try not to ask kids why questions, because why puts up those defenses right quick, right? If you want to tell somebody, if you want a quick pathway to getting an I don't know answer, is right away ask a kid a why question. Why did you do that? You're not going to give a solid answer then. What tends to help is when you start to go through kind of more subtle ways. We talk about, you got really upset when dad did that, or when mom said that. What's up? Or what was going on there for you? And you still might get that I don't know response, and that's fine. I mean, it's better than the kid making up a lie to you, right? That's not good for anybody to have a lie. So I definitely appreciate the I don't know answers more than I appreciate the lie. But you're definitely going to be more likely to get a good answer if we start coming alongside and avoid making the kid kind of take responsibility at that moment for the actions, because we want to get at the underlying cause. So meeting with them alone, again, you want to get a good adolescent on your side. You say, just talk to your parents. Oh my gosh, what's up with them, right? Quick way to align with them, and they'll be happy to tell you how their parents need therapy, not them. So we're generating hypotheses about what's going on with the kid. A meeting with a caregiver alone, again, generate hypotheses about what they think is going on with the kid, and trying to pull them away from, oh, he's just an evil kid, or he's a demon. Those aren't very helpful either. So we're trying to come up with some kind of working definitions here. And meet with them all together. I'm born as a family therapist. Got raised in that, if you want to talk about it that way, and talking and trying to meet with the family to see who talks to who, why, and when will give you mounds of information, even the littles that may be in the family. Littles are the best observers of family dynamics. They might not know why, but they'll know that daddy and mommy aren't talking to each other because when Jamie gets in a fight, mommy and daddy storm off, or when daddy comes home late, mommy gets angry. Those kinds of things. Kids are really observant about that. You'll get a lot of good things if you ask the littles about what they see happening or what they think is wrong. And sometimes it's just cute. So we want to grab all that information, try and get from them as many sources as possible. And then as we've collected this is where we start to get into some of the CPS information. So Collaborative problem solving starts with 3 plans, where they talk about the 3 plans when we address child behavior problems. And they're kind of out of order, but I'll tell you why this kind of makes sense. So our three plans are first plan A, which is insistence. This is the prophetic parent that says, this is what I say and it shall be done. I told you to do this and you will do it. The parent is the kid's doing what the parent's told because the parent's needs need to be met here. The parent needs the kid to sit down, the kid's going to sit down. Whether or not the kid wants to sit down, the kid's going to sit down. That's the parent problem. That's defining the parent problem, getting the parent need met. Plan C is getting the child's need met. That is when we know there's going to be an upset if Jimmy doesn't have his favorite cup. Parents are going to give the kid the favorite cup because it's going to keep Jimmy from having an episode, right? And even a little bit further than that, reducing the expectations of the kiddo. Maybe the expectation isn't that Jimmy puts on his shoes because I know that's going to have a tantrum for him and we're not ready to have that. So it's a bit of pick your own battles, but we're not doing the give in part here. Sometimes you can see this as given in, and it's really only giving in when we started with plan A, which is parent said something, and then we moved to the plan C, which is reducing the expectations. I told you to do this. Oh, never mind, you don't have to do it. If we're just off the bat not expecting the kid to do it because we've identified that this is a deficit of theirs and we're going to work on it, or it's not something we can address right now because we're working on something else, we're not really giving in because it's something we've identified that needs to be worked on. But we've not made it an expectation of the kid. And so this is on the forefront of reducing expectations. And then we have plan B, which is kind of in the middle, which is why they call it plan B, which is the collaborative problem solving approach. What this does is it tries to have everybody understand, the kid included here and the parent, of what each person is bringing to the table on the expectation and defining the problem. Okay, and we'll really get into this in just a second here. But the core of this is parents being what we call the surrogate frontal lobe. We'll get into that in a little bit here. But as a teaser, remember the frontal lobe is the impulse control part of the brain. And kids and human beings, it doesn't fully develop until you're about 25 years old or so for men. And a little bit earlier for women. And then if you're a man too, after 25, your testosterone starts going down. So we really only have maybe a year or two of goodness there. I'm sorry, after 30, our testosterone goes down. So we really only have about 5 good years of worthwhileness. So that's the idea of the surrogate frontal lobe is a big part of plan B. So plan A. In typical children, when we tell a kid to do something, well-developed children, there's a good relationship between the parent and the kiddo, not much trauma going on. The child's motivated by the insistence of the parent and the relationship. The kid wants to listen. It's an easier path. Yeah, there's some consequences. They know that if they don't get in the car, they're probably going to have something taken away. They know that if they don't come when mom calls, they're not going to have more time for play and things like that. It's generated by insistence and the relationship lost there in typical kiddos. And there's no extreme reaction to the insistence. We don't have the temper tantrum. They might get a little flare, perhaps a little tood. But I like to say, if you have a kiddo that's compliant about 80% of the time, you're doing well. That's where we want to be. In the explosive child, we get a bit of a different thing. We see these when adult expectations are pursued, the kid gets explosive, then the parent adds consequence. Even with realistic expectations, there increases the likelihood of outbursts. The kiddo just has some inflexibility in overcoming these deficits that they have. And so we get the outburst, we get the tantrum, because at times the kid literally just does not know how to handle it, how to process it, what to do differently. They know something's not right and they might not have an idea. Plan A is very quick on the front end. It's very easy. If I'm asking a kiddo to come stand by me and I say, come stand by me, or I'm telling a kiddo to come stand by me, that is, not having to go through plan B that we're going to get through, it's much quicker. It's much more quick. But it's also easier for a kiddo to say no. to that, and then to try the creative problem solving solutions. And so that's one thing to keep in account too, of these persistent problems. It's heavy on the back end. It takes a lot more time if we're having an explosive episode when you've started out with plan A than it will if we just try to do plan B. There we go. All right, there we go. That's why I wasn't running forward. Okay. So plan C, talking about reducing and removing expectations. We're not saying anything to the kid. We're removing the expectation that they even have to do. We're changing the demands to make, to kind of pick our battles here and just understand we can't work on everything all at once. If we work on everything all at once, you end up working on nothing. The downfall here when we talk about doing plan C, because there is a place for plan C, there is a place for plan A, and there is a place for plan B. When we talk about plan C and the need to do it at times, adults have that fear that we're giving in, that the expectations will never be met. And they feel the kid's not going to learn what the expectations are. And that's when I get to the idea and explain to parents, look, we can't do everything all at once. I know he's got like 15 tantrums that he's doing, and he's making life tough for you. And I want to start making life easier. We got to kind of chunk this out a little bit. Otherwise, we're going to have a bad time, right? We can't do it all at once. So our goal at first is just to give parents more resources, because parents get psychological resources depleted when kids are throwing tantrums too. They get frustrated and then they move to plan C. But if we just start with plan C for things that we have to move towards, and we'll reduce the overall number of outbursts to start with, and we'll be able to spend more of that time working on our plan B, because parents do only have limited amounts of time, right? Resources are finite. So a brief overview real quick of this mysterious plan B. Plan B's goal is to find a mutually satisfactory resolution. If you have a motto for plan B, this is it: mutually satisfactory resolution, addressing both kids and concerns of the kiddo. The goal is to spend less time needing to deal with an outburst of the kiddo. That over time with plan B, we're reducing the time it takes to handle the outbursts. Because once we start getting that resolution, there's not going to be the outburst, right? Kind of makes sense here. Reducing frequency, intensity of explosion episodes, helping our adults to pursue expectations that are reasonable, right? Reasonable expectations. That's key here too. Parents don't always have this idea of what's developmentally appropriate. Even if they've raised kids themselves. I recently was with a parent of a 2-year-old in my office. The kid was doing what 2-year-olds do. They were climbing, they were getting into things, or was in our waiting room here, or our conference room, and they were climbing and getting into things and playing with the toys and putting them on the floor and just scurrying about. And she said, and the parent exasperated said, she's always like this. She's always climbing on things. She's always trying to get in my lap and then come out of my lap and bring, and the parent was just basically describing kind of typical 2-year-old behavior. 2-year-olds climb on things. Yes, they do. I hear you. They'll get into things that they climb on, and we got a safety plan there. We got to assess the safety and make sure there's not glass things when the kids reach, and having supervision on them when they're in an area that's not totally sterilized. Kids are going to climb. They have this new power that they can have a whole new world that is a foot above their head. So they'll just climb on something to get it. So helping them pursue kind of reasonable expectations, somewhat through developmental normalizing, and again through our collaborative problem solving here. And of course, we want to teach them the skills that are to help teach the kid the skills that are lacking. And so that's why it's important to identify where they're lacking, right? We need to identify and help the parent teach the skills. So that's, again, what kind of makes CPS a little different here is we're not just solving the problem for the child, they're trying to help them learn the skills to do it. And a lot of that is done through repetition of addressing problems and having the parent go through this plan with the kid as a very big teaching moment. And so plan B is very much more efficient on the back end of things. The cell is just trying to help parents get more efficient on the front end. My thoughts are always on this is when you go to plan A that is telling a kid what to do, it's a gamble, right? It's absolutely a gamble because you might get a kid in a good time, who's in a good mood, and they'll listen right away. And the parent didn't have to do the things on the front end. And gambling can be a very addictive thing, right? He gets rewarded once in a while. That variable reinforcement ratio is very, very addictive. And so that's my own personal thoughts on why Plan A might be kind of our go-to here. Even for our explosive kids, when it's a losing battle, more oftentimes than not, you're not going to win the battle there with Plan A, and parents still pursue it. More often than not, you lose at gambling, but people still pursue it. So this also creates opportunities for more long-term success because we're doing that work on the front end. The kid starts to learn things. They start being able to apply this to their own problem. They start to feel like if I tell my parent what's really going on, they're going to understand me. They're going to feel heard. We're absolutely going to talk about one of the pitfalls that we all do that can really let a kiddo know that their concerns aren't important. And it's just something small. It's a very small thing and very powerful at the same time. So our basics of Plan B here. Let's get down into the nitty gritty, the basics. So Plan A or Plan C do not help kid learn those needed skills. They're not meant to teach skills. They're meant to either teach compliance or pull back from learning anything, or just reducing the expectation. Kids don't learn when we don't have expectations. Developmentally, kids aren't always equipped to handle those explosive episodes alone. All the models that we see of kids, especially younger kiddos that we see about how to handle a tantrum with kids is this idea of coming alongside versus coming on top. When a kiddo's throwing a tantrum, one of the things parents like to do, and we all fall in yours truly here too, calm down, just come over here, sit down in the chair, let's do this, grab your dolly, start to give kids commands on what to do. Quick hint, when a kiddo's flip their lid, when they're in full tantrum mode, they're not going to be paying attention. Their brain is shut down. The parts of the brain that handle regulation are not working, and it's going to be even more frustrating because those temporal lobes on the side aren't functioning their full capacity. Everything's not connected as much. It's not being processed for auditory commands there, and so they get more frustrated. It's almost like you're trying to speak to me, but I don't understand, and I'm even more frustrated. So we got to pull back, and parents got to come alongside instead of the top down. Parent needs to come alongside and be with the kid, keep them safe, keep the parents safe, and wait for the kid to get back together. It's got to work itself out at times because we can't let tantrums communicate needs for kiddos. That just reinforces the idea that that's the best way to communicate what you need is throw the tantrum. Plan B addresses that though. So as I said earlier, there's two types of this Plan B. We have the proactive part and then the emergency part of Plan B. And so we're going to talk a little bit more about the proactive part here today. So we got just to sum up real quick, we have to recognize those lacking in cognitive skills before the explosive episodes can be helped. Because we're not viewing the explosive episodes through that lens, the parent's going to be really quick to go through Plan A. They're really quick and just do this top-down approach of do what I say because I say it, and then boom. And again, as I said, parents do the thinking for the kiddo. We'll get to that in just a little bit. So this is what I'm talking about, surrogate frontal lobe for kids. We do this all the time for kids. The frontal lobe has the executive functioning, the impulse control, planning, and again, it's not really fully developed into your mid-20s. And we expect 18-year-olds to figure out what they want to do for the rest of their lives when their brain isn't still fully formed yet. That's another talk for another time. So in Plan B, the parent and the caregiver is really doing the thinking, the frontal lobe activity due to the kids lacking skills. And this idea of a surrogate frontal lobe, it's a new fancy terminology, but it's nothing new. When you teach kids to walk across the street, the first thing we do when we're teaching that is you have to stop, wait, look both ways. We're kind of narrating for the kid, right? All right, I'm gonna look left, I'm gonna look right, I'm gonna look left again. There's no cars coming, so I'm gonna go forward. I'm gonna go across the street, I'm gonna keep looking. Surrogate frontal lobe. Teaching a kid, wait for a baseball pitch. You're sitting there beside him, you got it up. All right, John, wait, go. Right? Surrogate frontal lobe again. How to learn to read. Surrogate frontal lobe. All right, slow down. Sound this out for me. Just did this with my 5 or 6-year-old last night. Tap it out. That's the new thing. Tap it out for me. And that's right. Now sound like this. Here we go. Lies, right? He's in a calm, neutral point. I'm helping him guide him through it because he has the capacity to understand what I'm saying since we're not in an explosive episode. We're doing the thinking for the kid at this point. And so this is helping him understand what to do. And through repetition, he's starting to tap things out himself. And oftentimes he will do it by himself. But that's because he's had someone help teach him this is the way to do it. And so this idea of the surrogate frontal lobe isn't new, but applying it to a behavioral problem kind of is, because it's not something we're used to doing. We are used to doing it though when we teach kids things, right? Because we understand they're not all there. When you're teaching kids math, we have step-by-step what they need to do. That's how math teachers teach it. They don't give it to them all at once in a paragraph. We break it out step by step, do chunking. Adults do very well with that too, by the way. So we got to do step-by-steps. All right. I said, mentioned we kind of already do this naturally for the kiddo. All right. Kind of talk about this already, walking the kid through the situation. We also try to do this when we with parents and have them think ahead. A parent thinking ahead and kind of recognizing, again, we have to do this when we talk about doing Plan C of what's going to cause an explosive episode. Being cognizant and paying attention and aware of all the things that could be going on for a kid, helping the kid think through, putting yourselves in their shoes. And empathy helps out a lot with that, which we'll get to in here in a bit. So precipitating that, kind of counting ahead. And so again, after multiple repetition, the kid's going to increase their thinking through. They're going to have an idea, almost a conditioned idea of what I'm supposed to do in this situation. We talked about kids, how to teach baseball and lacrosse. So you kind of got ahead of myself a little bit there. This idea of creativity and flexibility, though, I really like the way Plan B, and we'll talk about it here in a minute, addresses this idea that parents don't always have all the answers and brings the kid alongside. This idea of the parent has a need that needs to be met, which is X, Y, or Z. But and I see that the kid has parents like, I see you have a problem with it. What can we do to get both our needs met? So instead of me telling you X, Y, Z, what do we need to do to have this thing happen? And so the caregiver is modeling creativity and problem solving and flexibility and what they think should happen. And that's really important here when we talk about the kids feeling comfortable and talking to kids, knowing that the parent's not going to come continually from this top-down approach. Now, again, there are places for top-down approaches. Big fan of it when it's necessary. And there's a time to come alongside. And that's what Plan B is. So the rudimentary elements here. The key ingredients are going to be this idea that both people, you have to be doing this at a neutral time, not doing it when there is an explosive episode. We have to ensure that the concerns are clearly defined and we have to brainstorm. All right. All ideas are considered when you brainstorm and then we go back through. We don't start judging ideas right off the bat. Otherwise, the kiddo's not going to listen because sometimes the kiddos, how can we get you to get along with your sister? You can send them to the moon. If you say we can't send your sister to the moon, kid's not going to talk. So we have the 3 steps really that are necessary for successful execution. We got the empathy plus the reassurance. We're going to define the problem and this invitation of coming alongside. First step, empathy. Empathy has to be pulled apart and separated from this idea of endorsement. And I know you all see this. Empathy and endorsement are different. This empathy just creates the understanding, acknowledges the concerns of the kid and defines that concern. As the kid feels heard, they're going to stay more calm because they hear that you're hearing them. A highly specific definition of the kiddos is essential for successful empathy here. So that's where we start to drill down the problem the kid's having. You don't like going. I know, I hear you don't like going. For older kids, just I hear you. For younger kids, you don't like going to school. For anybody that's a PCITer, that sounds like an awful lot like a reflection, and it is. When you just repeat what the kid is saying, change that pronoun, bam, you have some empathy going on because you're letting the kid know I hear you. That's a very rudimentary first step to empathy. And as we're starting to let them feel heard and getting specific about what's going on for them, helps them feel understood, helps them know that you're there. This is a crucial point. And sometimes we have their 3 steps here. We're about to get into the second step. You can't do step one and then go right into step 2. It might take you a day of empathy, a day to show the kid you hear them, a couple of times of empathy before we're ready for the next step. Older kiddos a little bit easier. Younger kiddos sometimes, that mid-adolescent age, it can be more difficult. So, defining the problem. Plan A, get the parents concerned. What's your parent concern? C, what's the concern of the kid? And then B, reconciling the problem and concerns and talking about both the concerns of the child and the adult. And to define that problem, we have to recognize the pathways that are interfering with the ability for the kid to respond to plan A. Where is that deficit? You have to clearly define, and to do this, we have to clearly define the concerns of the kid through empathy and clearly define the concerns of the adult through investigation. The very big pitfall that happens. Oops, I didn't want to do this. Go back. The very big pitfall that happens here is the kiddo's going to say something like, to get the empathy of the kid, I know you don't like gymnastics, but I paid money, so you have to go. I know you don't like gymnastics, and if you don't go, we're going to be late. They very much skipped over the problem of the kiddo. Really, they did, and went right to plan A. They did not reconcile this part of the kid's concern and the parent's concern and going on to this part. You went from step 2 of plan B to right to plan A. This part is where we get at it. And so here at the end, the parents basically said, I know you don't like going to gymnastics. I see you get tantrums. What's up with that? What's going on there? You get hungry on the way to gymnastics. I got you. And that gets you really upset when you don't have something to eat. I hear you. I hear you. And I really want you to go because we paid some money for it, and it really helps you with exercise. So if you're hungry and I want you to go, what can we do about that? How can we get you there and help you not be so hungry? Aha, now we're going to brainstorm. So let's think about how we can solve this together, and very much include the kiddo in here. And the brainstorming is just a reminder, all options are on the table, even buying pizza and going to Chuck E. Cheese before we go to gymnastics. We're going to write them all down. Again, to help the kid feel heard. And validating it at this step without going through the problem-solving approach is just going to put things out. So how are we going to solve this together? What can we figure out how to do this together? These are all different statements we have parents use with kiddos. And assess the ability of the kiddo to develop. Remember, they have deficits. And so what the parent needs to do is figure out the ways they're going to get their needs met and the kids' needs met. This is where that surrogate frontal lobe comes in. Do they have the skills to generate the solutions? Do these solutions that this parent's generating take both adult and child concerns into account? Because if we're only paying attention to the adult concern of you don't like to go, I hear you hear the kid's concern, but you're not addressing it, and you have to go because I paid money, or you have to go because we made a commitment, we're not really doing any of this. We're invalidating the kid, and we're going to have a bad time. This invitation is the novel part about this, and it takes more patience, and this is where we say it's heavy on the front end. This invitation to pull alongside, and this is where CPS is really good for repetitive problems. Okay. As I said, the caregiver has to surrogate against that frontal lobe. So the burden is upon both people to solve the problem, to have some input onto what needs to happen here, and we have to make sure the solution is feasible. So that's why after we're done brainstorming, we go right through. Is it feasible that we can send your sister to the moon? I'm sorry, guy. I don't have a rocket in the backyard, but as soon as we get one, we'll talk about it. Fabulous. All right. I'm sorry, but going to Chuck E. Cheese. I love Chuck E. Cheese too. It's a fun time. I love watching you play skee ball. I don't have the time to get you there. Let's see what else we've talked about. What about you just being quiet and going? No, that doesn't work for you because you're hungry. Yep. So making sure both are addressed here. Here it seems that we have parents that really top-down approach or top-down specific. They may start to see this as, wait a second, I'm no longer a parent. I don't have any power in this situation. I'm giving up my parental authority, if you will. What we're really doing, now this is the key reframe, is we're helping the kiddo develop their lagging skills, okay? We're helping them see that you are a big part of solving the problems. We're teaching them how to solve it versus always relying on the parent for help. And that's something parents can rely on to. That's something to grab onto, is we don't want the kiddo to always rely on you to be able to solve things for them. And I guarantee you, they're going to feel better talking to you. And once they hear that you know that you hear them and understand them, they're going to be better at doing plan A when you have to do it. Because they want to listen, because they know they feel heard, right? But again, still trying to use plan B, because kiddos, that's a great way to teach them and address those lagging skills. The big litmus test here is making sure the solution is realistic, doable, and satisfactory. Okay. So before we talk about plan B to caregivers, we have to explain how the pathways, as I said earlier, making sure they know the issues and how to view the problems through that lens. We also need to have this informal sense of the ability of the caregiver to absorb the alternative view for the kid's problem. And we do have to have the caregivers kind of agree that it's crucial that they need to teach the kid these skills, that this is a collaboration. And before they engage in this, you have to make sure the level of hostility between the kid and the caregiver is a safe level. At a level where the kid's going to be able to think, because you're just going to get frustration if we're just on the tail end of a tantrum. Kid's still not ready to discuss. This has to be done at a very neutral time, even the next day after a tantrum. Okay. So you have the two forms of plan B. Some of these focus on resolving triggers, and some of them develop on lagging skills. So we have skill focused plan B and problem focused plan B, and they're all going to go through the same area here of trying to address what it is, whether this is a trigger or a skills deficit. The triggers, I think, tend to be a little bit more easy because they're easy for the parent to see. I think the skills lagging tends to lead to a little bit more of an investigation. But once parents start to pay attention to it, they can really better understand triggers. So a couple of final thoughts when we talk about plan B. Training occurs for the skills when the environments the skills are going to be utilized. It's very collaborative in nature. We're getting the kids to think about problem versus just react to it. And more ownership, they're going to more likely take ownership of the problem and trying to solve it as they go through this. And teaching adaptable skills is built into it. So I think I have maybe just a few minutes left for questions here, but I do want to provide the resources real quick. The Explosive Child, new approach to understanding parents and understanding and parenting easily frustrated, chronically inflexible kids. And just type collaborative problem solving in Amazon and you'll find the book. And it's a very affordable price. I think it's like 12 or 15 bucks. I checked it a few months ago.
Drew?
Yes.
Bonnie Ortiz asked if this presentation or any of this information is available in Spanish.
On the website of, I think it's livesinthebalance.org, there are kits and resources in different languages that they have available. That's what I'll say. And so I will always recommend, and this isn't something that takes any therapist to do, is for parents to get that book of The Explosive Child. It's a really, really helpful book. And if the clinician has the companion treating explosive kids, it will help them and the parent kind of come up with this together, because the Explosive Kids is much more written. I mean, anybody can get it out on Amazon, but it's much more written for the therapist and the underlying theory and techniques that it's used and why. So I definitely recommend clinicians to get that book. Well, thank you all again.